Hello, my name is Cale Melham. I'm a fourth-year medical student at IU. I've matched into PM&R for residency, and I had the opportunity to work on a case report with Dr. Katta-Charles over an interesting patient. So thank you for the opportunity for me to do this today. Our title of our presentation is Case Report, Post-Hypoxic Choreiform Disorder. So main objectives today are just to present this rare case of post-hypoxic chorea, draw attention to the differential diagnoses that are associated with post-hypoxic movement disorders, and we'd also like to describe challenges that may arise when managing the unique movement disorders in patients such as this. So giving some background information about our patient on this slide, this is not our patient pictured here, just a stock photo, but this is a 37-year-old female who sustained a pretty severe brain injury about 7 years ago, which was due to benzodiazepine and heroin overdose. She was said to have a downtime of at least 15 minutes, and the time for her to follow commands after sustaining her injury was roughly 3 weeks. So pretty severe injury. She currently lives at home with her family, although she also has in-home services and adult daycare services. But when we saw this patient and wrote the case report at that time, these services were interrupted by the COVID-19 pandemic. She follows up in an outpatient neuro rehab clinic with her mother, and her mother expresses concern that the family is currently unable to support the patient at home due to recent worsening behaviors and increased frequency in falls. And these issues have really deprioritized the treatment of her movement disorders, which I'll get into more. So on physical exam, our patient, she ambulates using a wheelchair. Cognitive baseline, she is confused, but she's alert and cooperative. She, on physical exam, demonstrates these constant involuntary movements of her upper limbs, which are consistent in direction and amplitude. They involve the parascapular shoulder and finger musculature with mostly forward flexion of her arms, which are followed by extension back down with simultaneous rotation of her glenohumeral joints. She also demonstrates ulnar and radial deviation of her wrists, which result in twirling of her fingers around the contralateral fingers. She is able to voluntarily suppress these movements for a few seconds. The movements are worsened when she is anxious or excited. Her deep tendon reflexes are hyperreflexic throughout. She has normal tone, no muscle atrophy. Sensation and strength are intact except for right hip flexion and right knee extension, which are significantly limited by apraxia. With the small amount of history I've given and physical exam, we can kind of start to tease out a differential diagnosis just based on what I've said thus far. So, obviously title of the presentation, post-hypoxic chorea, number one in my differential. The reason I think this is number one is because it's supported by the fact that she has these rhythmic upper limb movements. They're only during the day, and at all waking moments, they're not during sleep. Next on the differential is myoclonus, also known as Lance-Adams syndrome. This is actually the most common post-hypoxic movement disorder. It resembles more of a startle reaction. This is a sudden, involuntary muscle jerk or shake or spasm. It's known to be worsened by tactile stimuli and is often associated with generalized seizures. Next would be akathisia, which is a subjective inner restlessness resulting in motor restlessness. So these patients will report thoughts or urges to move a certain part of their body. So first manifesting as a thought, and then subsequently, due to these urges, the patients make the movement themselves. This is a common side effect of antipsychotic medications. Last on my differential is epilepsy, specifically frontal and temporal lobe epilepsy, because these can present with complex movements similar to what we see in our patient. The movements can also be described similar to bicycling, leg movements, hip thrusting, as well as even taking off clothing. However, with epilepsy, these movements would occur much more episodically, potentially during sleep, and they may or may not be associated with mental status changes. So this slide details some of the pharmacological management that had been used with our patient. The most important thing to take away from this slide would be the outcomes column all the way on the right-hand side, because the challenge with managing a patient who has both cognitive behavior and movement disorders is that treating one symptom may positively or negatively affect another symptom, which is one thing that made treatment very challenging for her. As you can see with methylphenidate, this was prescribed for cognitive fatigue, which it did do that in tension. However, this also worsened her movements, which we described. Escitalopram and SSRI was prescribed for her mood. It improved her mood, and it also improved her movements. The same could be said about aripiprazole, which is a partial dopamine agonist. Clonazepam was prescribed for her movements, and fortunately improved her movements and didn't seem to have other effects. To discuss this case a little more, I'd like to first start with getting into the pathology behind these movement behavior disorders. It's known that anoxic brain injury that is associated with basal ganglia damage, such as in our patient, does result in movement disorders, most commonly, as mentioned, post-hypoxic myoclonus. The reason for this is that the basal ganglia are very highly susceptible to oxidative stress in the event of a global perfusion insufficiency, and injury to the basal ganglia is associated quite often with both cognitive and behavior deficits. These deficits may be difficult to treat, given that medications that improve behavior may worsen movement disorders and vice versa, just as in our patient. To conclude, in the setting of global hypoxia, movement disorders are also likely to be accompanied by cognitive and neurobehavioral dysfunction. The main objective of this report is to raise awareness of the differential diagnoses of post-hypoxic movement disorders and the challenges that may arise when managing a unique array of symptoms such as these. Although rare, post-anoxic brain injury chorea could be a mainstay in the impedance of optimizing function, so early recognition of this disorder and other disorders is critical to the rehab process. Medications that improve movement disorders may also have a deleterious effect on cognition, so the challenge is striking a balance between optimizing cognition, behavior, and movement. Symptoms should be closely monitored when starting or titrating or stopping neuromodulating medications of any kind, and as clinicians, we should anticipate such challenges in order to avoid future problems during the rehab process. Here are my citations. Thank you again very much for the opportunity to be a part of this today.